Hello everybody. Today we're going to be discussing this paper that was published by the PI-RADS Steering Committee on the MRI biopsy pathway. It certainly has attracted a little bit of interest in Twitter, and you can see a number of high engagement rate. Three key messages from this paper. Message number one, high quality PI-RADS compliant MRI should be performed before biopsy in most men suspected of having clinically significant disease who are likely to be offered active treatments. Message number two, a safety net of monitoring must be in place for patients who decline immediate biopsy after a low likelihood MRI, and this should include clinical, laboratory, and imaging investigations as per local clinical practice. Message number three, for men who have positive scans, that is to say PI-RADS category 3 to 5 scans, combined systematic and targeted biopsies should be performed in biopsy-naive men. However, only targeted biopsies are needed for men who have had previous negative findings on a systematic truss biopsy. These messages reflect the recommendations of the 2019 EAU guidelines. And this comes on the back of a number of high evidence level prospective clinical studies, including the Precision Trial, the MRI First study, and the 4M study, and now multiple consistent systematic reviews and meta-analyses, including the very influential Cochrane review, which was also published in 2019. The Cochrane review is summarized on this slide. If you compare a systematic biopsy pathway where everybody gets a systematic biopsy compared to an MRI pathway where negative men get no biopsy and positive men only get a MRI-directed biopsy, the Cochrane review found that about 1/3 of men can avoid a biopsy completely, and there's a statistically significant reduction in overdiagnoses. You can see that the detection of clinically significant disease, whether you define it as ISUP equal or greater than 2 or equal or greater than 3, is only marginally increased. So the major benefit appears to be in biopsy avoidance and lowering the detection of clinically insignificant disease. What this means in clinical practice is that MRI is 12% more likely to make a correct diagnosis using fewer biopsies in a mixed outpatient practice. So if you had a prevalence of 30% of clinically significant disease in your practice, if you use systematic biopsies alone, you would miss 111, and about 1/5 of these would be ISUP greater than 3. On the other hand, if you use the MRI approach, which we've just said is no biopsies for negative men and only targeted biopsies for positive men, you would miss much fewer, 84 compared to 111, and the ones you did miss, the majority would be microfocal ISUP2s, very few ISUP3s. So you make more correct diagnoses using the MRI pathway. Of the 700 men that do not have clinically significant disease, you can see that on systematic biopsy, all 700 men would have to undergo a biopsy so that they could be correctly identified. However, on the MRI side, only 28 men would need to undergo a biopsy to confirm the absence of clinically significant disease. So you can see the impact of MRI not only in making a correct diagnosis in a mixed outpatient practice, but also doing fewer biopsies overall. And so these are the benefits of the MRI pathway. The pathway is shown on the right-hand side. You can see that subjects at risk of clinically significant cancers are often pre-stratified using clinical tools including PSA, digital rectal examination, and sometimes risk calculators. Those men who are deemed not to be at sufficiently high risk return back to their GPs. If they are considered to be sufficiently high risk, they undergo a PI-RADS compliant MRI, and if this is negative, provided that there are no high risk factors, they don't get an immediate biopsy. They return back via an MDT to their general practitioners. If they are positive or they are negative but have high underlying risk factors, such as a PSA density or risk stratification score or genetic history, they can undergo 1 to 2 biopsies, and if negative after biopsies, then they may return after a discussion to urological care. On the other hand, if they are positive, they undergo a risk stratified therapy. And the claims for this pathway are shown on the left-hand side of this slide, which shows, as we've discussed, reduced numbers of patients undergoing biopsy, reduced diagnosis of indolent cancers, increased detection of disease in prior negative biopsy men, and a greater precision of volume determinations for most patients. However, we have to acknowledge that the PI-RADS system is not perfect. So, for example, we know that up to 50% of men with positive MRIs who do undergo a biopsy have either negative histology or have only insignificant cancers detected. We now estimate that between 30 to 50% of men who get gadolinium contrast injections don't benefit from the injection. We've now beginning to realize that the performance of radiologists in clinical practice don't match those seen in higher volume centers. And this is because there's a steep learning curve for MRI interpretation and also, of course, for biopsy performance. And there is a level of expertise that needs to be arrived at to deliver the benefits that we've talked about. MRI, of course, is also time intensive, not only to review and report, but if radiologists are going to contour MRI lesions prior to MRI biopsy, that again will take time. One of the biggest issues that we have is that there are multiple quality issues for MRI acquisition, interpretation, and of course for the biopsy process. So how do we begin to deliver the promise of the MRI pathway so the benefits become available to all? There are a number of things that we need to think about. A major consideration is what to do with the MRI results. If the aim is to maximize the yields of clinically significant cancer, the so-called combined biopsy pathway needs to be employed, where negative patients undergo a systematic biopsy and patients with positive scans undergo both systematic and MRI-directed biopsies. This is the preferred route by many urologists. If the aim is to minimize the diagnosis of insignificant cancers, then men with negative scans should not go undergo a biopsy, and men with positive scans should only undergo an MRI-directed biopsies without systematic course. Of course, there is a middle ground where men with positive scans undergo both a targeted biopsy as well as a systematic biopsy. The decision is very much dependent on the prevalence of disease in patients with negative scans and in those with positive scans. So let's discuss this next, starting off with men with negative scans. By definition, men with negative MRI scans are at lower risk of having clinically significant cancers. If you took 100 men with negative MRI scans and you exposed them to systematic biopsies, 74% would be found to be negative. 18 men would be overdiagnosed with clinically significant cancers, but 8 men would be found to have clinically significant cancers and therefore would receive an appropriate treatment. In other words, to detect 1 man with clinically significant cancers, 12 to 13 men would need to be biopsied, but for every man detected with clinically significant disease, 2.5 men with insignificant disease would also be detected. Not doing a systematic biopsy after a negative scan would mean that we would miss 8 men with clinically significant cancers, and 3 of these men would have a high-grade ISUP3 or greater tumor. So what do we do to minimize treatment delays for these missed cancers? A robust safety net of monitoring clearly needs to be in place. We know that the majority of emerging clinically significant cancers will be found within the first couple of years, and a safety net monitoring regimen will be able to find these. Here's a couple of examples from the 4M study and the NICE guidelines regarding what a safety net monitoring regimen might look like. So if you look at the NICE guidelines, it recommends discharging patients to primary care if the suspicion level is low after a negative MRI scan. GPs are advised to perform PSA levels at 6 months and then every year thereafter, and then to re-refer from primary care to secondary care based on a rising PSA density or a rising PSA velocity. And this is what the PI-RADS committee recommends. For men with negative scans, a systematic biopsy should only be performed if patients are at high risk after a negative scan. And if they are not at high risk, no immediate biopsy should be performed, and a safety net monitoring regimen should be set up according to local priorities. And the EAU guidelines also recommend the same course of action. In biopsy-naive men, when the MRI is negative and clinical suspicion is low, omit a biopsy based on shared decision-making. When an MRI is negative and clinical suspicion is high, perform a systematic biopsy, again based on shared decision-making. There is also controversy about what to do with positive MRI cases. Remember, these patients are now at higher risk after having a positive MRI. If you wanted to maximize the detection of clinically significant cancers, then high likelihood MRI scans should undergo both a systematic as well as an MRI-directed biopsies. If you wanted to minimize the detection of insignificant cancers, then high likelihood scans should only undergo an MRI-directed biopsies without systematic course. There is a halfway house between these two extreme positions. If you wanted to increase detection rates but not compromise too much on overdiagnosis, you could do both MRI-directed biopsies and a focal saturation biopsies around an MRI-directed target. This really speaks to the added value of adding systematic biopsies to a targeted biopsy. The added value of adding a systematic biopsy to a targeted biopsy is 4.3% according to the Cochrane review. What does this mean in practice? If you had 100 biopsy-naive men with positive MRI scans, having both an MRI-directed and a systematic biopsies, you would diagnose 44 men with clinically significant cancers who would receive appropriate treatments. However, if you dropped the systematic biopsies and just did the MRI-directed biopsies, you would miss 5 men with important cancers because you didn't do the systematic biopsy. In other words, to detect 1 additional man with the clinically significant cancers, 20 men with positive MRI scans would need to have both MRI-directed biopsies and systematic biopsies. Now, clearly, if you're going to have a biopsy, the extra burden of more cause is less than in a negative scan situation, but this is something that we do need to think about. So why do targeted biopsies miss clinically significant cancers? It turns out that multiple studies are now showing that no significant cancer after a positive MRI are often due to targeting errors. If we look at the data, we can see that MRI detects about 90% of the clinically significant cancers that are there if we verify by a template mapping biopsy regimen. However, once we start doing targeted biopsies, you can see that the sensitivities fall, but the specificity begins to increase. In other words, the more cores you do, the better will be the sensitivity. The less cores you do, the greater is the specificity. So the clear answer for increasing sensitivity is to increase the number of cores. Should these cores be a systematic biopsy, or can we do a smarter targeted biopsy? If we look at the literature, what one notices is that the clinically significant cancers are often in sections adjacent to the MRI targets. And if you systematically sample normal appearing non-adjacent sectors, you do not alter the risk stratification in the majority of patients. Focal saturation around an MRI target increases the yields of clinically significant cancer without greatly affecting overdiagnosis rates. Here's a recent paper showing that you need about 4 to 5 cores per MRI target to detect the maximum number of clinically significant cancers that are present, although there is some compromise in the detection of insignificant cancers as a result. The optimal number in the framing of these cores per suspicious MRI lesion is currently uncertain, but it seems to be around 4 to 5 per target. Now it may well be that fewer cores from larger lesions and more cores from diffuse or heterogeneous or smaller lesions is what we should be doing. The EAE recommends performing a systematic biopsy together with a targeted biopsy for biopsy-naive men, but for patients who are prior negative biopsy, only targeted biopsies are recommended. So the PI-RADS committee agree that currently an MRI targeted biopsy plus a systematic biopsy should be performed in men who are positive. However, it does leave the option of doing an MRI targeted biopsy plus a focal saturation, in other words 4 to 5 biopsies, as an option in biopsy-naive men. Another difficult area is what to do with the PI-RADS 3 case. We know that there is a higher prevalence of PI-RADS 3 or indeterminate scans when inexperienced readers read scans or when the biparametric MRI approach is used. Even in the most experienced of centers, you can see that the PI-RADS 3 cases increases as you withdraw the number of imaging planes and withdraw gadolinium injections. We know that within PI-RADS version 2.1 that the number of PI-RADS 3 cases will increase within the transition zone. There is also a high but variable prevalence of significant disease within the PI-RADS 3 category, and currently there is no agreed way of separating higher and lower risk PI-RADS 3 cases. As a result, all cases get called positive and therefore need a biopsy. So how often do we see PI-RADS 3 cases? The overall prevalence within the literature is about 15 to 16%. Interestingly, the prevalence of clinically significant disease within this category is also about 18%. So a figure to keep in your mind is that the prevalence of clinically significant disease on average is between 15 to 20%, i.e. 1 in 5, and 1 in 5 of these men will have clinically significant cancers. So what do we do about these indeterminate cases? The first thing we can do is perform an expert peer review. Secondary reading can certainly be very helpful, and secondary reading should check if gadolinium contrast was administered. So here's a PI-RADS 3 lesion in the peripheral zone. If you look at the ADC map, you can see there's a focal area of decreased signal intensity in the left side of the peripheral zone, which may be slightly hyperintense on the high p-value image. Difficult to see, but if you looked at the calculated ultra high p-value at 1500, this suddenly is very suspicious that in fact there is a PI-RADS 4 lesion underlying this. However, it's quite easy to see that on contrast enhancement that this indeed is a PI-RADS 4 lesion. So the addition of contrast in this particular instance converts a PI-RADS 3 to a PI-RADS 4. Besides checking the quality of scans, an MDT review can also be very helpful when evaluating patients, taking into account the clinical history and the patient's priorities. Here, for example, is a 30-year-old man with what looks like inflammatory disease. This patient's priority is not to overdiagnose clinically significant cancers. The history clearly indicates infection, and although this is a PI-RADS 3 case, this patient does not require any biopsy. The PSA density can also be very helpful when trying to make biopsy treatment decisions in PI-RADS 3 categories, and this is shown by the data from the 4M study on the left and the BIDOC study on the right. You can see that a PSA density of greater than 0.15 increases the yields of clinically significant disease for higher PSA densities. The value of a central review is confirmed by this study, which showed that an expert radiological urological review does help to decrease the number of PI-RADS 3 and 4 cases, converting them into normal cases, and also changes the need for and the type of biopsies undertaken in patients who are positive. The last area I'd like to discuss is how we minimize variations in MRI reporting and biopsy rates. There clearly is a need to certify readers, biopsy operators, and accredit diagnostic units. We need to do this because the major benefits of MRI derive from reducing harms by decreasing number of biopsies and by reducing the number of indolent cancer detected. We know that experts have a higher normal call rate and lower indeterminate cases rates, and we know that experts can enable the adoption of the biparametric approach, therefore reducing costs. By minimizing variations within the PI-RADS categories, we can be much more certain of the likely prevalence of disease within these categories. And it is important to have a uniform, reliable quality for patient decision making. And this would increase confidence not only for patients but also for payers. We know that there's considerable variations between different studies in the rates of normal, intermediate, and positive scans. So if you looked, for example, at first biopsy studies, look at the variation between the studies of what was called normal. Look at the variation of what was called indeterminate, and look at the variation that we see between studies in what's called abnormal. Even within a given study, we see considerable variation between different readers for the different PI-RADS categories. So we've got variations between studies, we've got variations within studies for different reporters. We also have variations of the rates of clinically significant cancers within different PI-RADS categories. So if you look at PI-RADS category 3, we know on average it's about 12%, But if you look at the confidence interval, you can see it's from 4 to 14%. If we look at ISUP 2 cancers in PI-RADS 4 categories, on average it's about 30%, but it varies anywhere between 15 and 45%. So a huge variation even within different PI-RADS categories. To minimize variations, we need to think about accreditation of prostate cancer diagnostic units and certification of radiologists or urologists who interpret MRI scans and perform biopsies. Thinking about radiologists initially, training and mentoring and the learning curve are some things that we need to consider. The minimal number of reports per year that are being performed, benchmarking of positive cases, MDT participation, and audits need to be considered. The PI-RADS committee makes no specific recommendations on certification of radiologists and instead encourages local efforts which may be countrywide or region-wide, noting what's recently happened in Germany. Therefore, to conclude, there are multiple benefits of the MRI diagnostic pathway. We can identify about 30% of men who can successfully avoid a biopsy after negative scans. We can certainly reduce the detection of insignificant cancers. We can also increase the detection of clinically significant cancers in patients with prior negative biopsies and likely in first biopsy situations also. We now know that MRI-directed biopsies have a significant missed error rate, which reduces with more cores. We know that MRI diagnosis and MRI biopsies can work if we accept that we will not find all clinically significant cancers immediately and have robust safety nets for negative cases and for those patients with positive cases with negative MRIs. We know that the use of clinical biomarkers such as PSA density can help not only for patient selection but also for biopsy decision making. Importantly, we need to assure end-to-end quality of the diagnostic chain with robust multidisciplinary working. Thank you for listening. I hope you've enjoyed the video. Please read this accompanying article, which is freely available. If you have any comments, leave them for me. Thank you very much. Bye-bye.